Welcome everyone to the OHF On the Road webinar, a place to learn, engage, and connect with families, patients, and caregivers. Through this virtual webinar series, we are uniting to build and activate the hyperoxaluria community at a very personal level. Today's webinar is the third and final in this series, and we will connect on what's causing my kidney stones. But before we get started, we have a few housekeeping issues. Today's webinar is scheduled to last approximately 45 minutes. All participants will be muted to allow the speakers to present without interruptions. The webinar will be recorded for later viewing on OHF's YouTube and social media channels. To ask questions during the webinar, please use your Q&A box at the bottom of your screen, and we will answer them at the end of the webinar. If we run out of time, we'll follow up with you by email. We would like to thank our sponsors today, especially our partner sponsors, Alnylam and Dicerna Pharmaceuticals. Today's topic is what's causing my kidney stones. Kidney stones are common. If you haven't had a kidney stone, you likely know someone who has. Kidney stones in children, multiple kidney stones as an adult, and hyperoxaluria are not. Today, we will hear and learn from two kidney stone experts about causes, symptoms, diagnosis, and when to take that more in-depth look. Our guest speakers today are Dr. Kyle Wood, Assistant Professor, Department of Urology at the University of Alabama, Birmingham, and Associate Scientist at the Center for Clinical and Translational Science at the University of Alabama, Birmingham. We'll also hear from Dr. Lama Nizel, Assistant Professor at NYU Langone Health, and also Michael Spigler, Vice President of Patient Services and Kidney Disease Education at the American Kidney Fund. First off, we'll welcome Dr. Kyle Wood. Dr. Wood is a fellowship-trained endourologist. He got extra training, who specializes in all things kidney stones. His research passion is oxalate, and his surgical passion is helping patients when they have stone events. In addition, he sits on the OHF Scientific Advisory Board. I am going to now stop my screen share and pass it over to Dr. Wood for his presentation.
Great. Thank you so much. So hopefully you can see my slides. Make sure it's presentation mode. So we're going to talk a little bit today about the diagnosing and managing kidney stones. So what is a urologist? A urologist that specializes in kidney stone disease, both the workup and the management of it. Urologists in general deal with anything that has to do with the urinary system, whether it's the kidneys, the ureters, the bladder, or the prostate. We tend to be more surgical, and we rely heavily on our better halves, the nephrologist, for some of the medical and dietary and workup management, especially of kidney stones. However, because I'm a specialist in kidney stones, I have a keen interest on the workup and management, so I spend a lot of my days doing a lot of the things a nephrologist would do as well. Kidney stone disease is quite common, and it actually has a lot of things that are associated with it. So for example, if you have kidney stones, you're more likely to have kidney problems in the future. And as was mentioned by Julie, kidney stones is very common amongst the community. If you haven't had one, you probably know somebody who has had it. About 1 in 11 people in the United States will have a kidney stone in their lifetime. A lot of those people will have another stone event within 10 years. And even a smaller subset of people will have multiple stones. For a lot of individuals, stones can be associated with a number of other medical issues like high blood pressure or diabetes. Oftentimes people say, well, why does my kidney stone present this way? So these are just pictures, but the pictures are important to demonstrate that the kidneys lie in the back below the ribs, and they're not inside the organ parts. It's what we call retroperitoneal. They sit behind the peritoneum, or the part that contains all your organs. And so a lot of times when people present with a stone event or a passing of a stone, their initial pain is in that flank area below their ribs. And that stone will travel down what's called the ureter, which is the tube that connects the kidney to the bladder. And while that stone is passing down, the pain can be in different locations. So it can start out in the back, and it can start to travel up into the front part of the belly and then work its way down towards the pelvis or the bladder as the stone's passing. With those stones that are passing, people can have severe pain. They can also present with nausea or vomiting, and they can also have urinary symptoms such as blood in the urine or frequency of or urgency of peeing. And that all has to do with the location of the stone. This depiction just shows that the stone tends to get stopped up at 4 different locations. And so when it initially goes into the ureter, that tube that connects the kidney to the bladder, it blocks the urine flow and you can get pain in the side. And then when it travels over some of our vessels that go to our legs, called the iliac vessels, it can get blocked up there. And then as it enters into the bladder, it can get blocked up until it's pushed out of the bladder. Once the stone enters in the bladder, for the most part, people don't experience any further pain or discomfort. As a urologist, we manage these stones, and sometimes people need surgical procedures. And so this is just a depiction of the different types of procedures we perform. On the far left, you see what's called shockwave lithotripsy. Basically just a fancy way of saying we send energy waves through the body to the stone, and it breaks up the stone into multiple fragments. You still have to pass the fragments, but the idea is to break it up into small enough pieces that it's easy to pass. Some people benefit from what's called ureteroscopy, which is the middle picture. It's just small cameras where we go up into the bladder and into the ureter and into the kidney, and we can use special techniques with lasers to break up the stones and pull them all out. And that's what you can see with those pictures of the stones there. It's the little blue is the laser that's breaking the stone into pieces. And then in the figure E, you see a little basket that we use to remove the stone. And in figure F, you see that all the stones are removed. Some people have really large stones, and we can't really take care of them from either the first 2 means. And so we have to sometimes go through the kidney to get to the stones, and we can use larger pieces of equipment. What you see in the final picture there is just a kidney and then a tube that we put in through the back into the kidney, and then we go in with special instruments and break the stone up. This is a much bigger procedure and a much more specialized procedure, but it is used occasionally for people with larger stones or multiple stones or anatomy, complex anatomy that doesn't allow us to do the other procedures. Not all stones are the same. There's actually a lot of different types of stones, and each one can point to a different cause. So calcium oxalate stones is obviously the most common stone for patients with primary hyperoxaluria, and it's made up of calcium and oxalate, oxalate being the issue that we see in primary hyperoxaluria, the body making too much of it. But there are other stones, such as uric acid stones, other genetic conditions like cystinuria that form stones, and infection stones, which are called struvite stones. So depending on what the stone comes back as, we can know what the cause of the kidney stone is in the patient and have different ideas of how to work the patient up. Again, the most common type of kidney stone is calcium oxalate. And the details are not important in this slide, but it shows that most people that present with kidney stones will have a calcium oxalate kidney stone. These 2 pictures show some unique features about the United States, but also globally. Stone disease is growing, so more and more people are getting kidney stones and more people are requiring surgical management of kidney stones. We're considered, where I live in Alabama, the Stone Belt. It's an area of the country that's more common and more likely to have kidney stones. And so we see a higher proportion of people getting kidney stones and requiring management. The picture on the right is actually from Cook Medical, taken off of their website for a 2016 American Kidney Day. But you can see here that across the world, stone disease is a big issue. And actually in certain parts, is an even more common issue than in the United States. As I said, it's a lot of people that have kidney stones in their lifetime. So 11% of men and 7% of women in the United States will have a kidney stone. The next figures just shows that over time, over the last few decades, it's been a growing problem and more people are having kidney stones. We used to say that men were more likely than women to have kidney stones and Caucasians more likely than African Americans, but women are catching up, and actually the fastest growing population of kidney stones is in the African American population. So when do we decide to do a workup for kidney stones? And when should we be trying to figure out what's causing kidney stones? As Julie had mentioned in her slide, there are certain times where we think more about working up individuals. If you look at what the recommendation is, it's to work up any first-time stone former who's interested and every recurrent stone former. So if you've had more than one stone, you really should have a workup. This is where there's a disconnect between what the patients want and what the healthcare community provides. So if you ask a stone former whether they want to understand why they're forming stone, greater than 95% of them will answer yes. And so in reality, we should be working up greater than 95% of our stone formers. But as this figure shows, less than 7% or 8% of urologists are actually doing the appropriate workup for stone formers. So this is where it's important to get the community involved, to get programs like OHF and the American Kidney Fund and other organizations like the AUA to get involved, because we're able to educate the providers, but also educate the community. And by everybody being more educated, we're way more likely to work people up for their stones and then get to answers and then potential treatments. There's a lot on this slide, and it's not important to details, but it's just to show that not all stones are related to, say, oxalate, that there are a lot of different reasons why people can form kidney stones, and there's a lot of different things we can do as healthcare providers to help treat our patients with kidney stones and help prevent future stones. Knowledge is everything. So by using programs like the OHF or the American Kidney Fund or the AUA, which is the American Urological Association, or the Rare Kidney Stone Consortium, all of these organizations help provide community and members of the healthcare community opportunities to work up and engage their patients. And all of these programs support working up our stone formers. And so we really need to do a better job as providers to work our patients up. And as patients and family members of patients, this is a real opportunity to advocate for anybody that's having stone formation to get a further workup. This is the typical pathway that we kind of picture would be a great way to work a stone former up. And it's really getting the key, or the crux of it is getting those urine samples, 24-hour urine collections, to try to understand what's forming the stone. And then if those 24-hour urine samples show anything that we think could be a genetic cause, like oxalate, it would be getting genetic testing. And with the metabolic workup with urines and genetic testing, we can really come at an answer of why individuals are forming stones and help treat them. So focusing on primary hyperoxaluria just for as one example, if we did get a urine sample, a 24-hour urine sample on an individual, and they had high oxalate, that would lead us to possibly thinking they might need genetic testing and a workup for primary hyperoxaluria. And one of the interesting things is there is another disconnect, because we have a number of patients, many might be on this call, that have primary hyperoxaluria. But yet there's a lot of individuals that we think are underdiagnosed or not diagnosed out there. And that's purely based on genetics. If you look at what the frequency is of what we expect to have, we're not diagnosing enough people. Genetic testing, and you can go to the OHF website for this, but genetic testing has become easier to access. There's a lot that's happened over the last 2 decades, making it more affordable and easier to do. And so as providers and as the community, we have to start thinking about how do we get this to the hands of our patients, and when is it appropriate to work patients up? But it's something we probably should be doing more of as providers. So in conclusion, performing a complete workup of a stone former will help us understand the cause. It's probably time to embrace genetic testing as at least a part of the workup for stone formers. And at the end of the day, it's good to know, but it comes down to future research to understand and prevent. And as Albert Einstein said, any fool can know, the point is to understand. And so one of my main focuses on research, and one of the main focuses a lot of the programs, including the OHF, is on gaining more knowledge about these diseases. At this point, I'm going to hand it over to Lama Nazel, and she's going to take over and present some stuff.
Welcome, Dr. Nazel. Dr. Nazel is a nephrologist at NYU. She sees patients with kidney stones in her clinic and does clinical and animal research to identify new treatments for kidney stones and particularly diseases of hyperoxaluria. She was the recipient of several grants, including the Oxalosis and Hyperoxaluria Foundation, American Society of Nephrology Career Development Award. She also recently got NIH funding to study patients with bowel diseases and kidney stones. In addition, she sits on the OHF Scientific Advisory Board. Welcome, Dr. Nazel, and I will stop screen sharing and turn it over to you.
Thank you, Julie, and thank you to the OHF for this opportunity to share our knowledge with the public. And I will talk about diagnosing and treating kidney diseases. So I'm a nephrologist. So what is a nephrologist? A nephrologist is a doctor that treats kidneys. Nephro is kidney, just is someone who knows about it. So why do you need a nephrologist? Because most of the stones come from the kidneys, and they end up in the urine. So we need to understand what's happening in the kidneys to try to prevent them from happening again. So how do we manage kidney stones? So we have either general recommendations, like we tell everyone to follow a certain lifestyle modification, or we can have recommendations based on 24-hour urine results with or without genetic testing. As Dr. Wood mentioned, there is not a lot of people who do 24-hour urine tests, but those would be very helpful for us to identify what is the most important pathology and to help us suspect if there is any genetic disorder. And as you probably know, now there is development of newer drugs to treat primary hyperoxaluria. So knowing that you have a disease will allow you to get the right treatment for it. So I will focus first on oxalate. So oxalate, we get it from our diet, and it's also produced by our liver. It's from getting amino acids or proteins. They get broken down and then produce oxalate. And in our gut, there is a number of bacteria that can degrade or eat oxalate, reducing how much we absorb from it. Okay.
Dr. Nazel,
Yes.
we don't see your screen.
Oh, oh, sorry.
Just take your time.
Okay. Let me just close and reopen my PowerPoint. Having issues with sharing my PowerPoint.
Take your time.
Okay.
These things happen. Thank you, everyone, for your patience.
For your patience. Thank you so much.
Well, Dr. Wood, if we could just take this time, maybe I'll jump into a few questions that came in while Dr. Nazel is trying to share the screen. So one of the questions that just surfaced is how much meat per day is too much meat related to stones?
Yeah, so what we recommend is the best way to tell patients is that I tell them what a portion size is. So instead of getting into the grams of protein, so a portion size is literally the size of the palm of your hand. And so most Americans and many people around the world eat way too much protein because we picture a steak as a steak. And so I tell them that you really should only have a portion size, which is the size of the palm of your hand with each meal. And so that's usually the advice I give. Again, most people on 24-hour urines consume way too much protein and really should be reducing it significantly.
Thank you. And there was another question that came in that was really great. Can you explain how to collect 24-hour urine collections on young children who may not be potty trained?
I mean, in this scenario, spot urines are usually key to being able to tell, say, for an oxalate issue. And so that's sort of where most of us will just do spot urines in those children that are not potty trained. It can be very difficult otherwise. In spot urines, we're able to correct and reference it to other markers in the urine to kind of give us a reference range.
Perfect. And I just got word that Dr. Nizzel is ready to go. So we're going to hold the questions till after Dr. Nizzel. Thank you so much, Dr. Wood.
Can you see my screen now?
We can. Thank you.
Okay, perfect. I'll start quickly. So basically, yeah, so I'm a nephrologist. I treat kidney diseases, and I work with the urologist, Dr. Wood, and other urologists to help treat kidney stones, because the kidney stones come from the kidneys. So what we try to do is to understand what is happening with the kidneys, that it's producing or it's secreting in the urine components that are increasing the risk for kidney stones. And we try to manage that. So as Dr. Wood mentioned, you can do 24-hour urine collection, or we can just give general recommendation without doing 24-hour urine. We encourage 24-hour urine collections because that will help us determine the main risk factors for the kidney stones. And in some cases, that will guide us to think about genetic diseases. 24-hour urine is collected, as Dr. Wood mentioned, at home, and it's then tested for different components like calcium, like oxalate, that are the main cause of kidney stones. But they can look at other components like uric acid, that can be another form of kidney stone, or like citrate, which is a substance that can slow down the binding of calcium and oxalate and reduce the kidney stone risk. So I'll focus first on oxalate. So in our body, oxalate has two different sources. It's produced in the liver as from the product of breakdown of the proteins. It is also absorbed from our diet through our bowels or our gut, where a number of bacteria in our gut can break down oxalate and reduce how much we absorb. So what happens in hyperoxaluria, or too much oxalate in our urine? It could be dietary or from our diet. So we can be like eating too much oxalate in our food. Or it can be enteric or related to our bowels. If we have something like inflammatory bowel disease or the Crohn's disease, ulcerative colitis, that can disturb the bowels and allow us to absorb more oxalate. Or it could be also from bypass surgeries for losing weight. Or it can be primary hyperoxaluria, where we are producing a lot of oxalate in the liver. And each one of those would require different assessment and then treatment options. And then we can find we have a lot of hyperoxaluria, but we don't have a clear reason, and we call this an idiopathic or unknown reason. Okay, and all of the hyperoxaluria results in kidney stones. They result in a lot of oxalate in the urine and increase our risk for kidney stones. So oxalate is present in in our diet in almost everything we eat. It's in very high concentrations in, like, for example, all bran, in spinach and beets, and rhubarb, and soybeans, and dark chocolate, nuts, most of the nuts, and potatoes. So it's basically everything we eat or we are told is healthy. So what do we do about it? So we should first try to reduce the oxalate in our diet. The OHF has a list of the diet that is very high in oxalate, and alternative which are lower in oxalate. So we can know, for example, if you're eating too much almonds, which has a very high level of oxalate, you can replace it with, for example, pistachios or walnuts, which have lower oxalate level. So, and it helps to eat food when you're eating a lot of oxalate. We know oxalate and calcium, they bind each other. So sometimes if you really want to eat oxalate or you're eating spinach, it's helpful to eat something that has some calcium in it, like cheese or yogurt or something like that, for the oxalate and calcium to bind or not allow them to be absorbed in your gut. So they form like crystals and then go in the stool. So the second thing we tell people after reducing their oxalate in their diet is to keep hydrated. And that's the most important thing for preventing kidney stones, because the urine has a lot of substances inside, calcium, oxalate, and a lot of other things. It's very busy. So if you drink fluids, you're just diluting the amount, everything, and that will reduce the risk of things bumping into each other and forming those crystals. So we tell people to drink as much as they can. Like the recommendation is around 3 liters or 10 ounces glasses. And then to plan it ahead and drink consistently during the day. So for example, if you're going out, take a bottle with you so you keep hydrated when you're not at home. And then to pay some special attention during situations that may cause someone to be dehydrated. For example, if you're exercising or you're going somewhere where it's really hot. And then sometimes carrying an insulated water bottle is good. It can keep the water in a good temperature. And then also another source of fluids is high water content fruits and vegetables. So for example, watermelons, melons, things like that, they have a lot of fluids in them. And then you can take fluids beyond just water. You can, as seen here, you can add some slices of fruits to get it flavored, or you can drink some juices, but we tell people don't drink too much sugary or processed drinks. The second very important way we can reduce the risk of stones in general is reducing how much salt we take. So the average American diet has a lot of salt, and we can get salt from almost everything we eat, and especially if we eat outside. What is recommended is to eat less than 2,300 milligrams of salt per day, or around 1 teaspoon. This has been shown to prevent kidney stones, to extend the life expectancy, to improve bone health, reduce cardiac diseases, reduce risk for hypertension, for everything. So it's good to be aware of how much salt we're getting and try to reduce it. Okay, so instead of, for example, using salt when you're cooking, you can use herbs, you can use spices, peppers, that adds flavor without needing to add salt. And also, it's very important when you're buying something to know the labels and know how to read the labels. So when you're reading the label, it's very important to identify the serving size, because the serving size can be a tablespoon or a cup. So it's important to know, and then identify what is the salt. Salt can be sodium, can be salt, can be different names, sodium chloride, other names. So it's important to know, and then see how much they have. For example, if you have in half a cup 650 milligrams, if you're going to eat the whole like 3 or 4 cups, that's going to be very, very high amount of salt. And then the other part of the label will tell you about fat and cholesterol and other things. But I think it's very important to read the labels. And when you're buying things in the supermarket, for example, cheese, or look at the label and buy. If it has too much sodium, they have now alternative with either no sodium added or low sodium. Okay, so I hear this very commonly. So my patients in clinic tell me, since I was told I have a calcium stone, I reduced my calcium in the diet. This should not happen. It has been shown that increasing your calcium or dairy intake is associated with lowering risk for your kidney stones. The idea is if you eat calcium in your diet, that will help you prevent the stones and allow you to build up your bone properly. And then when you eat calcium, it binds the oxalate in your gut and allow you not to absorb it. So you get rid of it in the stool. So you should be getting around 1,000 milligrams per day. That's around 2 or 3 portions of dairy. We tell people to eat like yogurt, cheese, milk, but not all dairy is created equal. So try to limit the cheese that have high salt, because we told you that salt is not great. Like processed and hard cheeses, American cheese, cheddar, Munster, and some cheese spreads. Also avoid eating a very high sugar dairy products like ice creams or frozen yogurts and custards. So you have to be like to have dairy, but not like the very high sodium or very high sugar. And then I get asked, like, anything else we can be doing? As was mentioned by one of the attendees, they asked about the animal protein intake. And we tell people to reduce the animal protein intake and replace it with more like plant-based protein. And 1 serving of meat per day is all you need usually. And the size is, Dr. Wood mentioned the palm of your hand or the fist, your fist. So that would be like 1 portion per day would be good. And that applies also to fish, not only to red meat or chicken. So it's better to focus on proteins from foods like peas, beans, eggs, and dairy. And then finally, based on the findings from 24-hour urines, then if we cannot change if we cannot reduce the risk for stones with diet and lifestyle changes alone, we sometimes need to use medications. And we can reduce the risk for calcium stones using either reducing the calcium in the urine, and that's usually by using a medication group called thiazides. Those are diuretics, or they help you get rid of salt and water in the urine, but they can reduce the amount of calcium in the urine, so that will reduce your risk for forming the calcium oxalate stones. And then we can now reduce the oxalate only in primary hyperoxaluria with a targeted medication that was just very recently FDA approved, which is the Oxlumo, and reduces the production of oxalate in the liver. But what we can do is, as I mentioned more than once, if we give more calcium, we might be able to bind all the oxalate in our gut and prevent it from being absorbed. So sometimes we have to give people calcium to reduce the oxalate. And then citrate is a substance that reduces the ability of the calcium and oxalate to bind each other and form crystals. And that's another medication we can give to kidney stone patients. Those are either prescribed by the nephrologist or urologist, or we work together, and with the goal to reduce the risk for stones and prevent them from happening again. As Dr. Wood mentioned, if you have stones, you are at very high risk of getting them again. So to conclude, so nephrologists have urologists manage kidney stones. To prevent kidney stones, we need lifestyle changes and sometimes medications. So lifestyle changes include increasing water intake or fluid intake, reducing oxalate, reducing salt, reducing animal protein, and increasing calcium. Thank you for your attention.
Thank you, Dr. Nizal. I will go ahead and take the screen back here. And we will take it next to our question and answers portion of this webinar. Kim is going to hop on here with us. We've got quite a few questions coming in through chat, which is exciting.
It is. Okay, so I'll leave this open-ended to both Dr. Wood and to Dr. Nizal. So one of the questions that came in, if you're very active, can you eat more than 2 portions of meat a day?
So what I tell people, what I tell my patients is, really I'm trying to focus on it. That's why I said the grams I don't love, but 60-gram protein diet I think is a reasonable diet to be on for stone formers. So if you are really love meat, like I'm okay with them doing 2 portions, but recognizing that protein comes from a lot of different sources. And so really trying to focus on keeping your protein content to that 60 is what I tell patients. So yes, I'm okay with 2 protein portions.
Perfect. Thank you so much. I think this question might be great for Dr. Nizal. You talked about a lot with combining oxalate foods with calcium, like lactose and yogurt. But if I'm lactose intolerant, can I take calcium supplements instead of actually eating that yogurt or dairy product?
Yeah, this is a great question and we get it a lot. So studies have shown that it's better to get the calcium from the diet. So dairy is one of the most commonly recommended foods because it has very high calcium concentration, but you can get other foods that have calcium, like other fruits and vegetables that have higher calcium levels. We try to not get a lot of supplements because higher levels of oxalate from supplements have been shown to increase your risk for stones. So we prefer to get it in the diet. The idea is if you eat it in the diet, and that will be absorbed with other good things. So when you're getting a calcium pill, that's going to be calcium by itself. So we tell people, if you absolutely need the calcium for another reason, if you have bone disease or anything, we can keep it to a minimum, but try to increase your calcium-rich diet, not necessarily with only dairy.
Great, extremely helpful. Thank you. Okay, so questions are starting to stream. Let's see. When does a stone warrant a further workup for cause? And we'll maybe put this to the urologist world, Dr. Wood.
Yeah.
Yeah.
So as I stated, in my personal practice, I almost work up every stone former because if you follow guidelines, the recommendation is any recurrent stone former should have a workup. So if you've had more than one, and first-time stone formers, if they're interested, and based on evidence, I think all first-time stone formers, the majority of them, greater than 95% of them, are interested. So I think any stone former should have at least some workup, which can be 24-hour urines. When they have recurrent stone disease, more large stones, early onset, like a pediatric patient, if they have what's called nephrocalcinosis or calcium deposits in their kidneys, or if they have chronic kidney disease or the kidneys aren't working well, those are all telltale, like classic signs that we need to do more. And every one of those patients should get a workup for sure.
Awesome. Okay, so here's a question. I am sensitive to oxalate. I sometimes have funny feelings when it seems to be in my kidneys when I eat calcium foods like milk, yogurt, and sardines. Do I have stones? Should I be alarmed with all these symptoms?
I guess I can field that question. I think, anytime you have feelings, abnormal feelings that might be kidney related, I think it could potentially warrant a workup. So the easiest way to determine if you have kidney stones is by ultrasound. Sensitivities to calcium and oxalate tend not to manifest or present with problems in the kidneys per se, like if you take in calcium or oxalate, having symptoms in your kidneys. However, I think if you're having any symptoms, which I know one of the questions, can you feel pain in front and back? And stones can present with a lot of different feelings. So I will be the first to say the classic description is back pain, is flank pain, back pain, but it can present in a lot of different ways. So I think if there's ever any concern, ultrasound is a good place to start. There's no radiation with ultrasound, so it's a safe imaging modality to use.
Awesome. Thank you so much. Okay, so we're almost running out of time. So I think this question for Dr. Nozell might be great to close everything. I guess there's two parts of this. So is it normal if my child has a lot of UTIs? Should I be concerned? And then the second part of that question is, if I have too many stones, can I get kidney damage? So there's two parts.
Those are great questions. Yes, and it's not normal to have recurrent UTIs, recurrent or multiple urinary tract infections. It deserves to be worked up and identify whether it's one organism or multiple organisms. If there is an abnormality maybe in the urinary tract that's causing this to keep coming back, or whether there is a possible stone or something that's causing this to come back, and whether it's the same bacteria or different ones. So I think that should be worked up. For the second question, which was whether you can get kidney damage if you can get kidney stones, and the answer is yes, it's possible. There is different mechanisms where it can cause it's thought to cause this. It's if you have multiple times kidney stones that cause blockage, over time, those blockages multiple times can cause some damage to the kidneys. But also recently, there has been some research being done that identifies that those crystals can go in the kidneys and cause some inflammation because they shouldn't be there. So if you have crystals in the kidneys, those can cause like a small amount of inflammation, and over a long period of time, that can cause a kidney damage. And there has been studies finding association between chronic kidney disease and kidney stones. So that's why we tell people now to take kidney stones even more seriously, because over a long period of time that can lead to chronic kidney disease.
Thank you. That was very helpful. And thank you to both Dr. Nozell and Dr. Wood for all of your patience, understanding, and help during this incredible webinar. I'll turn it over to Julie.
Thanks, Kim. We also have a special guest today who's going to give us some information on Kidney Week that's happening with the American Kidney Fund. I think it's in June, and his name is Michael Spigler. Michael Spigler is the Vice President of Patient Services and Kidney Disease Education at the American Kidney Fund. Take it away, Mike.
Well, thank you very much, Julie, and thanks for the opportunity to talk to you all today. That was a really great presentation, and we've had such a good relationship working with OHF that I'm glad to be here today and continue that work. If you're not familiar with the American Kidney Fund, I just wanted to give you a little bit of an overview of who we are. We've been around since 1971. We are there for you kind of no matter where you are in your journey. And I think one of the key things that we do is, to that last point that was just made, we see lots of patients who end up in late stage kidney disease or kidney failure, never really understanding what their cause was. And one of the things we've been working with OHF on and some of our other partners is how do we help to do that? So we have a project called the Unknown Causes of Kidney Disease project that they've been helping us on. And you can find more information on that on our website as well. We have lots of diet information on our site as well. So if you do have a family member or someone that happens to be in dialysis or in transplant, you can search by those kinds of things. We've got very easy cooking tips on there as part of Kidney Kitchen. And should you end up, or someone ends up on dialysis or have a kidney transplant, and they need help paying for their health insurance premiums, they're in a disaster area, anything like that, that's really one of the things that we can help with too, with our financial assistance programs. But the main reason I'm here is to just briefly highlight and preview our 3rd annual Kidney Action Week. It is June 6th through the 10th of this year. It is 100% free. It's a virtual conference, so we'll have sessions running throughout the day, on each day, Monday through Friday. Not just the sessions themselves, which will be live, so you have a chance to ask questions of the speakers and interact. But we'll also have some recorded sessions to keep it going too, with some fitness demonstrations, some cooking demonstrations, lots of great things. Registration is going to open in late April at kidneyactionweek.org. But you can also just go to the American Kidney Fund website as we're streaming during the week, and you can just click right there. No registrations even needed. You can just watch the sessions there. What I'm most excited about is our session all about kidney stones, which we are partnering with OHF on. It is going to be on the Thursday of Kidney Action Week from 4 to 5 p.m. Eastern. We've actually worked with Dr. Sass before on a primary hyperoxaluria Facebook Live that we did in conjunction with OHF. So glad to have him back and participating again, as well as Dr. Lesky, both from Mayo. So we'll be talking kidney stones again there. So, if you log off today and you have a question that you've forgotten about, tune in there and ask the question there as well. So we'll have some great speakers and sessions there, but hope to see you there. And I just want to thank OHF for the chance to partner and talk to you today. Thank you, guys.
Thanks so much, Mike. What an incredible overview. And we're incredibly excited about Kidney Action Week. It's going to be unbelievable. And we're so happy to have a session with you all. So thank you for all that you do for patients in the community.
You're welcome.
Okay, so this is really exciting. We just wanted to bring this up. The Ouimet family, who have 2 children with primary hyperoxaluria type 1, opened their home to a young man that is from Nepal who couldn't get health care and needed a life-saving treatment. To read this amazing story, you can go to the link through this webinar, and it's going to hit stands any day. There's also a live broadcast. So if you check our OHF social media channels, you'll be able to find it there. And we just are so excited to read about this most inspiring story, to look at a patient advocate that has gone above and beyond every day to make a change in this world for patients living with primary hyperoxaluria. So congratulations to the Ouimet family, and congratulations to everyone that is part of this community. Thank you. Again,
And a big thanks. Oh, go ahead, Kim.
no, go take it away, Julie.
Thanks again, Drs. Nizal and Wood. And we also thank our special guest, Michael Spiegler. If you've asked any questions in the chat and we have not got to them, we will definitely shoot you an email after this webinar and get an answer back to you. Also, you can always stay up to date on what's happening at OHF. Just go to www.ohf.org. And if you see this picture, you know that you're there. We want to thank our sponsors again today for this webinar. And we want to especially thank our partner sponsors, Alnylam and Dicerna Pharmaceuticals. Everybody have a great day, and we'll see you on the next webinar. Thank you.